Hello, everybody, and welcome to a new episode of Home of Medicine podcast. Very happy that you've joined us today. My name is Ben Lovell. I'm a consultant in acute medicine and general medicine, and I work in London. And I'm here with my co-host, the fantastic Amy.
Hey, Ben, good to see you.
Thank you, Amy. I have got a case for you.
Okay,
I'm
I'm ready.
really interested just to hear your initial reactions to this one because it's a funny one. So I'm the consultant on duty. I'm on the take. I love it. I love being on the take. I love the general medicine of it. And we are referred a 36-year-old woman with two main symptoms, a throbbing headache and persistent yawning.
Oh, okay.
Initial thoughts, please?
Headache and yawning. I'm
Yes.
thinking carbon monoxide poisoning.
Oh, brilliant. I never even thought of that one. Okay.
Um, I don't know why that came to mind. It's probably that's bonkers. It's not going to be that. I'm thinking she might just be really tired.
That was my reaction. I was
You
like, headache,
know,
that's me every morning. Why is this pathological?
maybe we need to just ignore the yawning. That's a red herring.
Yeah.
Focus on the headache.
Yeah.
And identify whether we think this is a serious headache or a non-serious headache, and then always having the yawning in the back of our mind. I'm intrigued as to why she mentioned the yawning. Was this like a an excessive yawning?
Yeah. Well, this is the referral came through via the med on call, and they were displeased. I knew this was going to happen. You started yawning, and I thought to myself, how much are we going to be yawning for
It's
that point?
so
Like,
strange. I know.
so when you mention it, all the people listening are going to be yawning listening to us. Hopefully, you don't
Mm.
send anyone to sleep. But the Medred was displeased with this referral. Headache and yawning. I mean, come on. And they were having a bit of discussion about it amongst the team. And I said, you know what? I'm going to see this one. This I've got to see. Headache, yawning. Who goes to A&E and say I can't stop yawning? I mean, that's intriguing to me. But I've got to say, my first reaction was, I'm sure this is going to be either psychological or functional rather than an organic yawning disease, of which I couldn't quite fathom what that would even be. I mean, I guess if we're just playing free association football, what would cause pathological yawning? I don't know. But if I was forced to guess, it'd be something like a brainstemmy sort of issue because it's a brainstem reflex. So
Mm.
maybe you could get like a nasty brainstem migraine or someone's had brainstem injury after a stroke.
Medication? Is there any
Me-
medication that
Well,
could?
I thought medication because I remember SSRIs
Hmm.
increase yawning, but not like to any great degree. And I know that yawning is something on the checklist that we use for on our cows checklist, which is what our withdrawal from opiates. So you know how you score people to see what they're withdrawing, how they're withdrawing from alcohol as an inpatient, or do they need any benzodiazepines? There's another spreadsheet for people withdrawing from opiates and yawning and
Okay.
sneezing, as well as piloerection and shivering assigned to that. So opiate withdrawal, brainstem demyelination or inflammation, MS. Anyway, that was going through my brain, but I wanted to see this patient. I thought this was quite intriguing. So I went to see the patient with a very open mind. And the history was it started the previous night, couldn't stop yawning, just one after the other, and a headache. And the yawning, she says she's yawning every minute or so. And she's now, stop yawning, Amy. Now she's been yawning for 24 hours, every sort of minute. And she's a bit embarrassed about this. And the headache, she says, throbbing, global headache, came on over an hour, not a thunderclap at all. And she thinks it probably began maybe around her right eye, but then went to her whole head. And it's about 6 out of 10 in severity. And I asked her, do you have any photophobia, any meninges, a stiff neck or fever? None of the above. No visual changes, no trauma, no aura preceding the headache. And she wasn't a migraineur. She'd never been diagnosed with a primary headache disorder. In fact, she'd never really been diagnosed with anything. She had no past medical history of note. She had mild anxiety diagnosis when she was at uni, but this was never medicated. And she doesn't take any medications, no allergies, and she works as a freelance graphic designer, which is mostly sort of computer screen work. Drinks 1 or 2 glasses of wine at a weekend, and no smoking, no drugs. Lives with her boyfriend, and that was her. And the whole way through the conversation, very regularly was, oh, oh, another yawn. So of course I started yawning in sympathy, but it was quite unusual. I hadn't seen it before. Any thoughts now?
I'm going to put you on the spot here. Why do we yawn?
Nobody knows. It's thought to be evolutionary, thought to be a social signal, like blushing and crying and
Mm.
laughing.
Mm.
And while it doesn't offer any evolutionary advantage to the individual to yawn, it doesn't sort of clear your throat or anything like that. It's thought to be a signal, a social signal. So when you yawn, it's contagious. Other people yawn around you, and it's bonding. So small tribes and groups of people would become more bonded and therefore be more likely to look out for each other and look after each other and ensure group survival. The same as blushing signals social unease and laughing signals pleasure. They don't actually do anything from a sort of organic point of view, but they serve to embond and enmesh societies and cultures and therefore ensure group survival because you're more likely to stick around with each other. Is
So I'm just thinking, when you bond with somebody, the hormone that gets released when you connect is oxytocin. So oxytocin is released when you've had sexual intercourse. Had this started after she'd had sexual intercourse?
No, there's no evidence as to sort of post or
Okay.
pre-coital headache or any
Okay.
sort. No,
Okay. And the only other thing I'm thinking, dopamine. So, but you said that she hadn't any taken any medication or.
no,
Hmm.
no. Just sitting there yawning at me, complaining of a headache.
And I did mention carbon monoxide poisoning at the beginning. Is there anything that could suggest this?
No, fortunately.
Okay. Okay. So I'm going to, oh, this is tricky. So I want to separate them into the headache. So I want to find out what type of headache this is. So you
Yeah.
sounds like you took a subarachnoid hemorrhage history and a migraine history. Could it be tension headache? Could it be cluster headache again? It doesn't fit that pattern. Very unusual to just sort of start. Doesn't sound like there's been any trauma, that it could be a traumatic brain injury. Doesn't sound like there's any infection going on. Can I have some observations?
Sure. So temperature was 36.8, heart
Yeah.
rate 82, saturation is 98 on room air, blood pressure is 122 over 78, and the respiratory rate was 16. And on examination, she was alert, oriented, no evidence of clouding of consciousness or delirium, but she was yawning constantly. And a neuro exam was cranial nerves were normal, normal motor, normal sensory exam, and the cerebellar exam was normal as well. And when I saw her, actually, she'd already had her bloods done, and they were really completely unremarkable. I've got all the results here, but I'll tell you everything was within normal range. CRP was less than 6. And she'd even had a CT head, which I think Amy had done because of the headache, and that was normal also. So the only thing I'm thinking of now really is that she's got this persistent yawning, which is it's a semi-conscious or semi-voluntary reflex, but it seemed to be happening to her, and she was pretty cheesed off by doing it, and she wanted it to stop, and she was a bit embarrassed by it, but it wouldn't stop at all. It was sort of this persistent autonomic reflex going on and on and on.
Hmm. Blood glucose?
Glucose is normal.
Okay. Does she take, you said she didn't take any medication. Does that include contraceptive pills?
She did not take the contraceptive pill. Any
Okay.
reason why you're asking?
No, I
Oh,
don't
okay.
know. Well, I was thinking headache. Could this be a venous
Okay.
thrombosis? But I'm really thinking laterally now. That was the only reason I asked about that one. Hmm. Was she on her period? Was she menstruating?
I've got to say, I didn't ask.
Okay. Because you often find that as a woman, things are different when you are on your period. So I'm always quite keen on asking that question. Although sometimes you can then blame the menstruation when it probably isn't. So you have to be very careful when you try and elucidate that. Any family history of anything?
No,
No.
no.
Does she need pain relief for the headache? Is it that bad that she wants pain relief?
She had taken some paracetamol, and that was
Okay.
it.
Had
Yeah.
it helped?
It had taken the edge off slightly, but it was still present.
So to summarise, we've got a 36-year-old female, fit and well, no past medical history of note, who
Mm,
presents with a 1 hour onset of a 24-hour headache, global 6 out of 10 with excessive yawning.
mm.
Normal observations, So far, normal blood tests. CT head is completely normal. Examination was completely normal. Is she pregnant?
No, because her pregnancy test was negative.
Okay. So I have no idea. So I'm going to work down my surgical sieve. So could this be vascular? So you've talked about infarction, and if you've got a brainstem infarction or bleed, you're not going to see it on a CT, so you might want to consider doing an MRI so you can get a bit more of a detailed imaging. Could it be a bleed? Well, we know that we've ruled out a large bleed because you've done a CT head, which was normal. Could this be infection? Bloods were normal, no pyrexia, no symptoms suggestive of infection. So, not really. Trauma, she denied trauma. Autoimmune condition, very strange, it would just start the night before. Metabolic, we looked at a glucose, which was normal. Any other metabolic conditions not going to have started the night before, really. Iatrogenic, has something happened to her? So, had she been drinking alcohol? I said no.
No, no more than usual. No,
No drugs.
no.
Um, she works. Does she work from home or is she going into an office? Is she actually surrounded by noxious gases?
Mostly at home.
Okay. Um, Neoplasia. So CT was normal, nothing to suggest a malignancy. And you said that she'd taken no medication, doesn't take any drugs.
No, she does not.
Okay, so you've got two options. Number one, you either go, do you know what? This is just one of those things. Let's watch and wait. Because if everything's normal and she looks well, CT head's fine, you can send home with reassurance, say, please return if, it continues to be problematic. Or you could do an MRI head
Hmm.
um,
Yeah.
to identify, and I think you ask 50 people, 50 people will probably tell you different things, and you probably have a 50-50 split. So you probably get some people discharge, some people do more imaging. I'm not sure where I sit at the moment. I'd probably be so intrigued, I might do the MRI.
It's really interesting because what would you put on the MRI request? I would feel a bit self-conscious about writing the yawn
Oh,
if they laughed me out the building. I think if someone had persistent headache, an MRI is not unreasonable. And
yeah.
I know that people who are being worked up in neurology clinics for a diagnosis of migraine do have an MRI as part of that workup to rule out any kind of structural problem. So I think the headache history alone, I could see how you can get an MRI. But did I want to put the yawning down? I mean, I want them to answer a certain question, but yeah, that would be an interesting conversation with
Mm.
the radiology desk, wouldn't it, about whether or not that the MRI was indicated. I wondered this to push you in a certain direction. I mean, and I always say to patients who I see with headaches, I say, are you a headachy person? For example, if someone asked me that question, the answer is, yeah, I do get headaches, unfortunately. I get tension headaches, with sleep and whatever, alcohol. So I say, are you headache? Have you had headaches before? And she says, well, I have had similar headache. I've never had the yawning before. Oh, very long conversation because she's yawning all the time. But the headaches, I've had this before. It's funny. I get these headaches and then with this, just after I get this very funny metallic taste in my mouth, then I get this headache, and I get this very strong sense of deja vu.
Oh,
Oh, yeah, a little light bulb appeared over
a
your
little
head.
light bulb. I'm just thinking seizure activity.
So I said to her, "What happened with the yawning then?" And she
Yeah.
says, "Yeah, I had the yawning." And I said, "Do you notice any unusual symptoms?" Them attached, but not the taste. But I had before it happened, a headache and the yawning. I had a really, really strong sense of deja vu, which I just find really strange. And I had the same
Ah,
thing. So talk me through what's going through your mind at the moment.
temporal lobe epilepsy.
What makes you say that?
So, number one, it's strange, the presentation, but there's something wrong for her to present to hospital. So, I'm not happy that this is okay. Number two, the deja vu. So, that feeling that you've been somewhere before can happen with a temporal lobe epilepsy. And the metallic taste in the mouth could have been the aura, and the headache could be a post-ictal headache after the activity. So I'm thinking temporal lobe epilepsy. I'd probably like to go down investigating for that. So I would do an MRI anyway, because I want to look at the temporal lobe to see if there's any changes, and also speak to neurology and thinking about getting an EEG as well.
Absolutely. And it's exactly the same sort of light bulb flash that I had as well. And because this was first thing in the morning, I was able to get an EEG that afternoon. EEG, would you like the result?
Yes.
Uh, Intermittent right temporal sharp waves consistent with focal epilepsy of the temporal lobe. Diagnosis, temporal lobe epilepsy with autonomic aura, compulsive yawning, and a post-ictal headache.
Oh my word.
You got it.
With a lot of prompting. Wow, that is a really interesting case. So, treatment-wise, the impact of treating epilepsy is huge, isn't it? Like the medications and the impact it can have on lifestyle for the individual as well. So, talk me through how you manage this case.
So of course we clinched the diagnosis. We got the MRI as well, and you're absolutely right. The MRI showed temporal mesial sclerosis,
Mm,
mesial temporal sclerosis, MTS. And this is right mesial. It was the right mesial lobe, temporal lobe, sorry, and it showed some hippocampal atrophy on the right-hand side, which is the classic finding in temporal lobe epilepsy. Hippocampal sclerosis or mesotemporal sclerosis, it's actually it's damaged the hippocampus really, and there's some conflicting evidence about whether it's caused by childhood febrile convulsions or not, or previous trauma or infection will do it. But often we just don't know why some people have it, but it's a substrate for seizure. It interrupts usual electronic signaling within the brain, and it's a substrate. It's like any scar or structural abnormality, and it's a substrate for temporal lobe epilepsy. You cannot see it on the CT because it's a brain structure. You need the MRI to it. So the MRI showed the substrate for the seizure, and the EEG showed the seizure as well. And she was established on levetiracetam, Keppra, very successfully. She had clobazam at bedtime for a few nights, and then she was established on levetiracetam. She was referred to the outpatient neurology clinic and given usual advice about people who had a first fit. Now, she didn't have a generalized tonic-clonic seizure, and it did not cause impaired awareness. But in patients like these, you do want them to be fit-free before they drive. And usual advice you give anyone who's had any kind of seizure about being home alone, locking doors, making sure you're not in the bath with the door locked and things like that, just in case this seizure were to generalize. But I thought this case was really interesting because on the face of it, it's almost laughable, the presentation. It's almost a case of, for goodness sake, what a stupid, why would Amy refer this? Send them home. But sometimes they know something's slightly wrong, the
mm,
patient knows something's slightly wrong. And what really clinched this case was asking about any unusual symptoms you noticed at the beginning of your this episode, and that's when the deja vu came out and the metallic taste in the mouth came out as well, which kind of moved the chess pieces around and got us into a place where we can get the diagnostic test done, which was the EEG.
So, what I'm thinking of, the diagnostic test confirmed the diagnosis, but actually, where did that diagnosis come from, Ben? The history.
Mm.
Again, I know I say this all the time. The history is so, so, so important. And it's about asking those questions. What happened at the beginning? Deja vu. Oh, and when you mentioned that, I was like, this could be temporal lobe epilepsy. We didn't need fancy tests. We needed that to confirm the diagnosis, but we got the diagnosis by talking to the patient. I really, really, really worry that we don't have the time to talk to patients as much as we used to. And I worry that people have more tests that they don't need because we're not able to take as thorough, comprehensive history as we could have done 10, 15 years ago.
Because not all the data you need comes out. They don't blurt it out and volunteer it. We have
Mhm.
to tease it out.
Exactly.
And that means we have to take the time to listen and reflect. I
Yeah.
read I read a piece about a medical history very recently, and it put it in very grandiose terms. And it was saying what the medical history actually is not simply going through a checklist. It is the physician in real time, contemporaneously listening and then testing
Mm,
in hypotheses in a conversation. I was like, blimey, that's a lot of words for asking questions, but sort of get what they're saying. It's not something you can do with half your brain listening. It's not something you can delegate to a checklist on a computer or a form the patient could fill out because you have to pull teeth sometimes. You have to follow little clues,
mm,
not follow red herrings. You have to go down little alleyways in the history and say, whoa, what was that last thing you said? Sorry, just tell me more about that last thing. And then go, actually, no, that's not relevant after all. We can put that down. Okay, back to the main story. We have to know where the blind alleys are and where what's actually going to give us some fruitful information. And
mm,
it's a really, really good skill. And we teach it in medical school and what have you. But I think that all we can do in medical is teach you like a script. You then have to develop your own edit of it,
mm,
patient by patient, and that's the skill. And
mm.
unfortunately, the skill can only be enhanced by seeing lots of patients.
Mhm.
ties into ongoing conversations and actually about how long medical training should be, and should it be shorter, and should people be doing less of this and more of this. And sometimes there is an impression that medical training is off the shop floor. It's people in a classroom or having a PowerPoint or a workshop or something. That's training. Everything else is service provision. But getting all those patients and those histories under your belt
So
is
important.
long work. It's sometimes incredibly hard work. Sometimes going to be tedious work. Just patient after patient after patient after patient, history after history after history. But it is a type of learning, and you've
Mm,
got to put the hours in. Just like learning to play an instrument, or learning to ride a bike, you've got or learning to juggle. You've got to put long, boring hours in on the
mm,
shop floor at the coalface for you to
mm.
actually get the skills out of it the other end. That's my little hobby horse, anyway.
Do you know, one of my most fulfilling parts, I think, of being a doctor is when there are two. So one of them is when I'm sitting with a patient and I have time with them and I actually get to take a history and we talk about lots of different things. And that for me brings me so much joy and it makes me realize why I do what I do. That very quick, rapid triage I find really stressful. And secondly, is trying to teach this or show this to the doctors of tomorrow as well, and whether they be undergraduate medical students or resident doctors. And it is a skill, I think. You definitely need to do it a lot, and I think the skill of history taking is maybe not felt to be as important as it used to be. I've certainly noticed that, but
Yeah,
yeah,
it's very frustrating because here is
yeah,
you dribbling on about, oh, you've got to do, you take time and do the history, and that's the most acute tool. And then we go to work. I'm saying, hurry up, hurry up. You've only seen one patient this
I
morning.
know.
And that's unbelievably stressful as a
Yeah.
resident doctor. And these two utterly conflicting pieces of
Hmm. Hmm.
advice. But
Yeah.
it's unfortunately, well, we live in, so it's all about trying to find moments of learning and moments of teaching. And the responsibility lies on us as consultants to be giving feedback and
Mm.
not sacrificing that on the altar of trying to get everything done in the shortest time available.
Hmm. Yeah, absolutely. And I think it's a very, very, very difficult balancing act at the moment about time spent with the patient, time spent on the computer, which, a lot of time is there now. Yeah, there's lots of challenges, um, which, but we're getting there. We still have our jobs.
So I'm going to give a couple of take homes just in
Yeah.
case my yawning lady helps other people. Um, Yawning is a brainstem driven behavior, but it's driven by higher cortical structures, particularly the limbic system. And there's so many temporal lobe structures which project into the brainstem as well. When do you worry about yawning? I would say any neurological impairment or any other brainstem signs. That's when you start thinking, could this be autonomic activation that's not under the patient's control? The EEG is critical if this story doesn't add up, basically. And if you're thinking about temporal lobe epilepsy, ask about deja vu. Ask about funny tastes and smells. Ask about brief episodes of altered awareness that they or a witness noticed. And ask about post-ictal headaches, post-ictal confusion, post-ictal mood changes. And sometimes that can be the key that unlocks the case. I hope you found that useful, Amy. And next time you see a yawning patient, you will probably say, are you tired? Yes, but also, could you have temporal lobe epilepsy?
It was absolutely fascinating, and it's just made me think of, you've mentioned deja vu, but also jamais vu,
Jamais vu, yeah.
which
What is
is
jamais vu?
it's sort of the opposite, isn't it? When you're with somewhere, but it feels very new and familiar,
Yeah,
even though they've been there before, it feels completely new.
yeah.
I feel like that sometimes when I'm at work with the kids. Yeah. So
I get deja vu. I get deja vu. I
yeah,
don't
me
think I'm
too.
having terminal epilepsy, but I get it maybe once a year. I'm like, oh, deja vu. I've done this
It's
before.
weird, isn't it?
Yeah,
Yeah.
never had a jamais vu. I've never been in a situation going, I don't know who you are, what's going on. That would be quite distressing. But deja vu, I
Mm,
do get from time to time.
mm. Thank you so much, Ben. That was enlightening as ever. And
Thank you.
I'm just trying to think of what I need to call this episode. Maybe just yawning.
Yeah, and if we made you yawn at home, I do apologize. Hopefully, nobody nodded off while operating heavy machinery or driving a car. But thank you so much for listening. Amy and I just want to say we really, really love it that you listen to our podcast, and we really enjoy doing it. So thank you so much for taking the time. We love it when we meet people or people reach out to us and say they enjoy it. That really makes our day. So please don't be shy about letting us know if you get something out of the podcast. We will always respond. And If you rate and review the podcast, apparently it grows it somehow and it gets presented to more people in the world who might pick it up and listen to it as well. And of course, you can recommend it the good old fashioned way, face to face with your friends. And if you think they might get something out of it. So thank you so much for listening. And thank you, Amy, for joining
Thank
me today.
you. Bye.
See you next.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.